Just for everybody, we'll before we start, we'll wait a minute or so just to let everybody log in. Okay, so we'll start. Good afternoon and welcome to our EANS webinar on established and emerging techniques of decompressing the injured brain. I also want to welcome my fellow panelists that will give the presentations. We have Angelo Scolias from a neurosurgeon from Cambridge, Christian Søndergaard, resident neurosurgeon from Copenhagen, and last but not least, Sandra Kriek, neurosurgeon and department chair from Heidelberg University in Germany. Before I start, I also want to express a warm welcome to all our non-European colleagues joining. Good morning, good evening, might probably be more applicable for you. Also want to mention some housekeeping issues. We'll take approximately an hour in total, which means 20 minutes for each presentation, including questions. And questions can be asked, of course, but please use the Q&A function for that. And I'll then address these questions at the end of each talk. Okay, so let's start. Without further ado, I'd like to introduce our presentations. Of course, everybody knows when talking about decompression of the injured brain, most will have the reflex that pertains to performing a decompressive craniectomy. When thinking about a decompressive craniectomy, many will inherently think about the large RCTs that have been done the last 10 years, 15 years. So that will be our starting point. And who better than Angelo Scolias to guide us in this evidence base? While Angelo shares his screen, I will introduce him. So Angelo Scolias is a consultant neurosurgeon at Addenbrooke's Hospital in Cambridge, UK. He's affiliated to Cambridge University as a clinical lecturer and has last year been appointed as a so-called Hunterian professor by the Royal College of Surgeons of England. And together with Professor Peter Hutchinson, he has been the major leaders of these rescue studies. And those will be the focus of his talk. So thanks, Angelus. I'm looking forward to your talk.
Thomas, thank you very much for the invitation, and welcome to everybody who's observing this webinar today. Thanks very much to the EANS Trauma and Critical Care section for organizing this important meeting and for the invitation. So I'm going to start by discussing about the background to the randomized trials, and you've seen that I think most people are aware of the two randomized trials that we published. But in terms of starting the presentation, we should try and distinguish between a primary and a secondary craniectomy. And I think that's an important starting point. So a primary decompressed craniectomy is when we leave the bone flap out following initial surgery for a mass lesion. And this is usually an acute subdural hematoma with or without contusions. But sometimes you may even have an extradural mixed with a subdural that has also contusions. So occasionally you may do it for other indications or potentially a large traumatic ICH. On the other hand, a secondary decompressed craniectomy is when we remove a large bone flap. This can be a hemicraniectomy or a bifrontal craniectomy to control raised ICP. So in those cases, there isn't a big mass lesion that needs to be evacuated, but those patients are typically managed in an ICU in a tiered ICP protocol to control raised ICP and maintain CPP. I'd like now to take a step back and look at the beginning of the modern era of craniectomy. So this is the original paper by Harvey Cushing, published back in 1908 in the Annals of Surgery. And you can see this is his conclusion of the paper, where he says that prompt exploration and decompression is necessary in his view, rather than waiting for nature to take her own course in absorbing extravasations, this means hematomas and contusions, and edema in an open skull. And this very much in a nutshell describes the whole premise of decompressed craniectomy. So you have an open skull, this again is the monarchical doctrine, and by doing a decompressive craniectomy, you can control ICP quite effectively. However, 60 years forward, so this is a paper that was published in JNS 1968, people started performing craniectomies. Usually this would be a bifrontal or a hemicraniectomy. But you can see this is a very impressive title of a paper. So they say the failure of circumferential craniectomy in acute traumatic cerebral swelling. And the conclusion is even more impressive. So they say the reason for reporting this experience is to warn others from doing similar surgery. So as you can see, there were mixed feelings about craniectomy. So the concern traditionally has been that by performing a craniectomy, we are saving lives, but this comes at the expense of vegetative state and severe disability. So this was 1968. Now in the 1990s, with the modern era now of trauma care and neurotrauma care, with the increase in the utilization of CT and MRI scans, and also the technological advances that meant that ICU became what we now know as ICU, so the modern ICU. There was a resurgence of interest, and this is a paper in a book edited by Alan Roper. Alan Roper is a very well-known neurologist and neurointensivist from the United States, who actually was the handling editor of the two papers that we published in the NHAM on craniectomy. So what he said was that there is a resurrection of a practice that failed several decades ago, and he was calling for controlled trials with careful attention to inclusion criteria and timing. And I think at this juncture, it is important to tackle this question: why do we need randomized controlled trials? And this is often something that comes up, and I'm going to be the first one to say that we don't need a randomized trial for everything, because many people will, make jokes and they will say, oh, why don't we do a randomized trial for parachute jumping or for extradurals? So we don't need a randomized trial for everything. But the point is that when we compare treatments, two treatments or more treatments, the two groups of people in the study should be as similar as possible, except for the treatment they receive. So this is a very fundamental, it's a very basic principle. And this is important because it means that any differences in outcomes between the two groups can then be attributed with certainty to the treatment they receive, rather than any other differences like, age or a better prognostic profile. And the decision about which treatment each participant receives is made at random in a randomized trial. And this is so far the best way to minimize selection bias. So there have been many advanced statistical methods that we have employed recently and, and have taken part in such studies. But so far, nothing seems to be better than a randomized trial in terms of minimizing that selection bias. And the problem is that if you have doctors choosing which treatment a patient should receive as part of a study, then she or he might offer the new treatment to patients who are worse, sicker patients, or to younger patients. And this could either exaggerate or may even hide treatment effects. So I'm not going to spend any more time on this. I think I already have an invitation for a webinar on randomized trials by the research committee. So moving on to the craniectomy trials, there are two major trials of secondary craniectomy: the DECRA study, which took place mainly in Australia, but also New Zealand and Saudi Arabia. They enrolled 155 patients. It was published in 2011, also in the NHAM. And they included patients with a severe diffuse TBI within 3 days post-injury, but the ICP had to be just above 20 for 15 minutes in an hour. So this was a very mild, moderate degree of intracranial hypertension. On the other hand, in rescue ICP, we included 400 patients up to the age of 65. The ICP had to be raised above 25 for at least 60 minutes and refractory to tier 1 and tier 2 medical treatments. In DECRA, it was only refractory to tier 1 medical treatments. And I'm going to analyze these two studies first, and then I'm going to cover Rescue ASDH, which was the study that looked at primary craniectomy, so patients with an acute subdural hematoma that needed to have a trauma craniotomy or craniectomy to evacuate the subdural hematoma. In terms of the secondary craniectomy trials, they had different hypotheses. So the DECRA examined the role of bifrontal decompression as an early or what we call a neuroprotective treatment. And they found that it does not improve outcomes following diffuse TBI. In Rescue ISP, we looked at craniectomy that was a bifrontal or a hemicraniectomy as a last tier therapy for refractory post-traumatic severe intracranial hypertension. Before I look at the results of the studies, I'd like to remind everybody of the extended Glasgow outcome scale. So the extended Glasgow outcome scale, as you know, it was published, the original scale the extended scale in 1981 by Brands and et al. And it is an 8-point scale that ranges from death up to upper good recovery. Death is usually equal to 1 and upper good recovery 8. Having said that, it's not a numeric scale, it's an ordinal scale. A couple of points that I want to highlight is that we have vegetative state and then we have severe disability, which is distinguished in lower and upper severe disability. But these are very different in terms of what they mean for the individual patients. So with lower severe disability, you have somebody who is dependent on others for all care. So those patients would typically be in a nursing home. They can't get out of bed. They cannot sort of look after their bodily needs. They're full dependent. On the other hand, by definition, upper severe disability patients would be independent at home for at least 8 hours in a day. And as you can see, this is very different. So even though both are named severe disability, very different outcomes. And then you have moderate disability, lower and upper. So these are patients that have gone potentially back to work, maybe in a voluntary capacity, so not what they used to do in the past, but they have started going back to work. And then upper good recovery is recovery with no further problems. In terms of the DECRA study at 6 months, which was a primary outcome, you can see that the rate of mortality was very similar in both arms, so 19% in both arms. But there were more patients in vegetative state and upper and lower severe disability. So as a result, the rate of poor outcomes at 6 months was 70% in the surgical arm versus 51% in the medical arm. That was statistically significant when they adjusted for some baseline imbalance in the rate of pupillary reactivity. This was not statistically significant anymore. But I think what we can conclude from this is that there is no evidence that craniectomy was beneficial. And the 12-month results also showed this. So we can conclude that early neuroprotective craniectomy was not beneficial for mild, moderate intracranial hypertension. When we move on to the Rescue ISP study, and if you have a QR code reader on your phone, you can look at the paper, but not now, later on, if that's okay, when we finish. But the study was organized again in 3 stages, similar to DECRA. So stage 1, we had the simple treatment measures. If the ISP was above 25, we moved on to stage 2. And this is when we used optional treatments like ventriculostomy, inotropes to maintain CPP, mantle or hypertonic saline, hypothermia optionally. Barbiturates were not permitted. If the ISP was above 25 for at least an hour, then patients were randomized at stage 3 to craniectomy or medical treatment with barbiturates. And these are the treatments that patients received. So you can see that a similar number of patients had craniotomy for evacuating a hematoma before randomization. Similar number of patients had ventriculostomy, neuromuscular paralysis, and therapeutic hypothermia and osmotherapy. After randomization, you can see that the majority of patients in the surgical arm, so 93% had a craniectomy. Most of them, so 2/3, had a bifrontal. You may ask, why not everybody? Well, because, for example, a few patients went into the OR and they became medically unstable, so they had to abort the surgery. They didn't proceed. And then you will see that if you look on the medical arm, about a third of patients had a craniectomy, and this was allowed by the protocol, this crossover, simply because if they had exhausted all of the treatment options, including barbiturates, and the ISP was high, patients were unstable, then they could cross over to the other treatment. However, the analysis took place in the intention to treat populations. All patients were analyzed as per the original allocation. And this is important for statistical reasons to, again, to try and minimize the bias. And you can see that about 10% of patients in the surgical arm had barbiturates, and 90% in the medical arm had barbiturates as well. And this allowed, it's a pragmatic study in a real world randomized trial. These things can happen. But as I say, because the analysis happens in the intention to treat population, they do not affect the results. Now, if we look at the 6 months Glasgow outcome scale, and we have collapsed this into 3 major categories. So death is black, vegetative state and lower severe disability is red, and everything else is green. You can see that there is a significant difference in mortality, so 22 percentage points between the surgical and the medical arm. However, there are more dependent patients in the surgical arm at 6 months. This was not statistically significant different, but at 12 months, we had a statistically significant difference. The mortality difference persists. Now the rate of dependence has decreased, so it's only 9% percentage points difference between the surgical and the medical arm. And then you have about 13 percentage points difference in terms of the upper severe disability or better in favor of craniectomy. If you look at the ISP parameters, these were all favoring craniectomy. This is not a surprise, so I'm not going to spend any more time on this. But this makes sense, and we knew that already, but it was confirmed by the study. So patients that had surgery had better ISP control. What is interesting is that we recently published in JAMA Neurology the 24-month outcomes of rescue ICP, and I have this diagram organized at patients at 6 months, 12 months, and 24 months. And you can see that the mortality difference persists, but if you look at the surgical arm, and if you look particularly at the right-hand picture of the diagrams, you will see that there seems to be an increase in the rate of the better outcomes from 6 to 12 and to 24 months. And also there is a decrease in the rate of the poorer outcomes, that is vegetative state and severe disability. This is just by looking at this diagram. This was confirmed statistically, so we found a statistically significant difference in the surgical group between 6 and 24 months. So in other words, patients in the surgical group were more likely to improve over time compared to patients in the medical group. So the majority of the patients remained stable, about 6%, but we had about 30% of patients in the surgical arm that improved by at least 1 grade between 6 and 24 months. And this underlines why it is important to continue follow-up in these patients. Another way of looking at this is to look at the outcome of extra survivors with a craniectomy. So at 24 months, for every 100 patients treated with a craniectomy versus medical intent, we end up with 21 extra survivors. About 30% of those will be dependent, but the rest, so 70%, will be at least independent at home or better. I think we have looked at the difference between DECRA and Rescue SP already, but I say they're very different studies, even though people tend to lump them together, very different studies with different hypotheses. So we should be looking at them as complementary studies, but not as similar studies. So DECRA looked at an early neuroprotective craniectomy. Rescue SP looked at craniectomy as a last tier, last resort therapy. I'll move now to the rescue ASD8s, if that is okay. So this was a study, a trial that was targeting patients with significant trauma requiring evacuation of an acute subdural through a large trauma bone flap. And patients were randomized intraoperatively in the operating theater. The sample size was 440, and the primary outcome was 12 months excellent Glasgow outcome scale. We also looked at other endpoints, including quality of life. Patients had to be adults with an acute subdural on CT, and the admitting neurosurgeon felt that the hematoma needs to be evacuated with a large trauma bone flap. Indicatively, we said that the size had to be above 11 centimeters. So patients with a simple acute subdural, elderly patients, alcoholic patients that do not have significant trauma, and they only have a small bone flap to evacuate that subdural, were not included in this study. Okay, and as said, patients were taken to the operating theater. The trauma bone flap was elevated, the hematoma evacuated, and then the patients were randomized unless there was significant swelling preventing safe replacement of the bone flap. So if the brain was bulging outside the inner table of the skull, the patients were not randomized, but were followed up in the observational cohort of the study. Otherwise, they were randomized to have the bone flap replaced and fixed, or the bone flap left out. We had 40 centers in 11 countries enrolling patients: UK, India, Canada, Malaysia, Germany, Spain, US, Australia, Hungary, Pakistan, and Singapore. And many thanks to all collaborators, anybody who enrolled study. We couldn't have done it without you. And you can see here the flow chart. I'll just highlight that 462 patients were randomized, 407 were enrolled in the observational cohort. In the craniotomy arm, at the time of the original surgery, 20 had a craniectomy. This was because the brain, for example, started bulging after the randomization had taken place, and this sometimes can happen. And then in the craniectomy arm, 12 patients had a craniotomy. This was usually because the surgeon had second thoughts, or a senior surgeon, sometimes this did happen, a senior surgeon walked in, had a look at the brain, and said that the brain looks relaxed. We shouldn't follow the randomization, we should put the bone back. And these things do happen in the real world, and the analysis again was on an intention to treat basis. And if we look at the characteristics of the patients at baseline, and you can see why randomized trials help in that way, you have two very balanced groups. So the age was 48 in both groups. Majority of patients were male, and very low use of antithrombotics, because this was not, as I said, a patients of elderly acute subdurals. This was younger patients with significant trauma. About 14% had blood thinners on board, and majority of them were had a low GCS below 8 to begin with, obviously. And then in terms of the CT scan findings, again, very balanced. So majority had significant midline shift above 5 millimeters with compressed basal systems, and about half of them had also contusions in addition to the acute subdural. If we look at the surgical details, just simply highlight that most of them had a question mark type incision, a drain. It was used in most of them, subgaleal drain. The bone flaps were of adequate length, so about 13 centimeters from therion to posteriorly, so good sized bone flaps. And then in terms of other hematomas evacuated, about 80% of patients did not have another hematoma evacuated. And then, as you can see, about half of them had a monitoring device used. If we look at the primary outcome, and we analyzed the Glasgow outcome scale as an ordinal scale, which it is what it is, so it's an ordinal scale. We use ordinal analysis. And if you look at the global odds ratio, you will see that there is no statistically significant difference between the two arms. The odds ratio is 0.85. It is crossing one, so there is no statistically significant difference. But then if you look at the diagram, and I think it's much better looking at the diagram rather than just the percentages, you will see and I'm looking at the top panel, which is the primary endpoint at 12 months. Craniotomy is at the top, decompressed craniectomy at the bottom. You'll see it looks like that there is a slightly higher rate of better outcomes, so upper good recovery, lower good recovery, pretty much everything in the craniotomy group compared to the craniotomy group. And even the rate of low severe disability and vegetative state seems to be slightly less in the craniotomy group compared to the craniectomy groups. So this is just a trend. Statistically, this difference was not significant, but there is a trend there that we can see. And if you look at the quality of life analysis, again, there is another trend. So it's not statistically significant differences here that we can see, but the mean quality of life outcome score is better in the craniotomy group, even though it's not a significant difference. Now, if we look at the ICU length of stay, very similar in both arms, so about 10 days. And if you look at the therapy intensity level, because some people said, well, you leave the bone flap in, so those patients may need higher intensity of ISP lowering treatments. But this was not proven by this analysis. So a similar number of patients reached a peak TIL of 2, 3, and 4. And you can also see that the median number of ISP-directed therapy days was 8 in the craniotomy versus 10 in the craniectomy group. So similar, we didn't seem to find any differences there. In terms of the surgical endpoints, and I think these are very important for a surgical audience, but also for any audience, to be honest. One of the endpoints was further cranial surgery within 2 weeks. And we found that 15% in the craniotomy group had further cranial surgery within 2 weeks versus 7% in the craniectomy. If you look at those more carefully, you'll be able to understand that 9% of the craniotomy group patients had to have a decompressed craniectomy after an initial craniotomy. So that is the rate of patients that have to go back to the operating room after the original surgery to have the bone flap taken out because of issues with edema and raised ICP. However, this is counterbalanced by the high rate of wound complications, including surgical site infections. And we have all seen those complications with craniectomy, the high chromas, the CSF leaks and infections. So it was 4% in the craniotomy group versus 12% in the craniectomy group. So this is something which is quite useful to bear in mind. This is the paper that we published in the NHAM. And again, if you have a QR reader, you should be able to access this. So to try and wrap this up, as a summary, I think we now know that early neuroprotective bifrontal craniectomy for diffuse TBI with mild, moderate raised ISP is not useful. This is what the DECRA study showed. On the other hand, the rescue ISP study showed that a last year craniectomy is a life-saving intervention for refractory raised ICP. We found that the craniectomy patients continued improving beyond 6 months. And at 24 months, almost half of them were at least independent at home, versus this is of the survivors, versus a third of the medical group. In terms of the rescue ASDH study, we found that it suggests that there is no difference between craniotomy and primary craniectomy. And the practical implication of this, and this is what we have started doing, is that the bone flap should be replaced unless this would lead to compression of the brain. And I have started performing some Hinge floating craniotomy in our patients as well in Cambridge. Obviously, the craniectomy questions are laden with a lot of ethical issues. My personal view on this, and we can discuss this later on, is that unless the prognosis is bleak, so unless we are dealing with brainstem injuries, somebody with bilateral fixed and dilated pupils, a secondary craniectomy should be considered for patients with refractory raised ICP ahead of barbiturate coma. And I think discussion with family and with the multidisciplinary team is key. So multidisciplinary team means the intensivist really, or the neurologist. And just as a closing message, I think only living patients have the potential for convalescence and rehabilitation. In other words, if you have somebody who has died, you can't really rehabilitate them, can you? So finally, lots of people thanked, but mainly my colleague and mentor, Professor Hutchinson, and also the rest of the neurosurgeons in Cambridge, also the intensivists in Cambridge and rehabilitation physicians, but also the global neurotrauma group. We have a very active global neurotrauma group with lots of colleagues from Asia, Africa, and South America. And finally, all of the collaborators. If you'd like any further information, feel free to get in touch via Twitter or just simply by emailing me. Thank you very much.
Great, Angelos. Outstanding, as always. I've seen your presentation a couple of times now, but every time I'm impressed. So looking at the question and answers box here. So despite an impressive amount of attendees, I have no questions here. So I'll just have some short questions for you, Angelo. So you clearly show that there's further improvement in terms of the rescue ICP studies. I study that there is a further improvement going from 6 to 24 months. Do you think that there's a reason to assume, knowing that DECRA might have shown also a benefit if you would do the functional outcome at 2-year time point?
Yeah, thanks, Thomas. That's a good question. So if you look at the 12-month outcomes, which is it has been published in the Journal of Neurotrauma, there was no sort of significant difference between the two arms, because the question is there a difference between the two arms in terms of DECRA that we may have missed by looking at the outcomes early? So there was no difference between the two arms. There were slight improvements in patients. We know this, that patients can continue improving beyond 12 months. But as I say, in terms of the question, is there a difference between the surgical and the medical arm? There wasn't one.
No, and you
wasn't one. Yeah.
And you won't expect that to be, if you look even later, as you've seen. No, the improvement was less as clear as rescue. Yeah.
Correct. No, I wouldn't expect to be so, because there was no signal at 6 or 12 months.
Yeah.
I mean, simply what happened is that those were patients, and at that point in the early notice, there was this question, whether we should be doing a craniectomy early on to save the brain from becoming ischemic, etc. So lots of people were doing it, but the threshold for randomizing was really low in DECRA, and also patients only had tier 1 treatment, so they didn't even have osmotherapy.
Yeah, it was not exhausted, indeed. Yeah, it's a different patient domain we're talking about there.
Yeah.
So a little bit building up to our next presentation also, Angelos. What do you think might be like new surgical interventions which you think that will show? You mentioned Hinge, of course, but which you show will have the most promise in TBI? And not only Hinge, but we have laparotomy, but we also have, we're not discussing that today, but cystinostomy, a very provocative intervention, of course, or innovative, depends on who you're asking. But I can imagine you can talk for an hour about this. I want to remind you that try to be brief, but we need to go to the next question.
I'm not going to talk for an hour. I mean, very briefly, in terms of what we now do, in our practice in Cambridge, is since the rescue SDA's results came out, we have really now limited the number of primary craniectomies to only those acute subdurals where the brain is really bulging out and there is no way of putting the bone in. If the brain is not bulging but is filling all the way the space up to the inner table and there are some contusions, we do perform a floating or a hinge craniotomy. And obviously, we leave a nice pimondo and we carry on with medical management of ICP. I mean, cystinostomy, even though people talk about it as an innovation, cisternal opening, it was described by, Yasagil, and, it's been around for a very long time. And we know that, if you open the cisterns, the brain does relax. This is what we do in skull-based surgery and also vascular neurosurgery. So, I can see why it would be working as well, potentially in some trauma cases. But again, the question is, would it work in those cases with significant edema, and also, at what expense does it come? because access can be a little bit difficult, and also in particularly in resource limited settings, you wouldn't have a microscope, you may not have a high-speed drill, all those things that you will need to perform the cisternal opening safely, to get all the way to liqueous membrane. Some people even drill the posterior clinoid. So this is a slightly more advanced technique. I can see why it would help, but as I say, it may not be for everyone. That's the issue, and I think that we do need some evidence generated in terms of that.
Yeah, very clear. So I guess the question is, should we trial it, right? And I think we know who to go to if we need a trial. That is you. So thanks, Angelos, again. We'll now move on to our next presentation. Well, as you've all seen, the conclusion of Angelos is clear. Improved functional outcome in all cases of refractory raised ICP, and in acute subdural hematoma, it's not necessary to as a preventive measure, at least. And so there's where there's no imminent swelling during the surgery. However, what also became clear in his last slide, or his pre-final slide, is that decompressive craniectomy has an impressive complication profile. So can we improve on that while we at the same time ensure that the functional outcome benefit is maintained? And that's the premise of the next talks. First, Christian Sundergaard, senior resident neurosurgery from Copenhagen, will guide us into his work of hinge craniotomy. Christian, the floor is yours.
Thank you. I'll just share my screen. Hang on. All right. Can you see the screen? Great. So thank you, Thomas, for inviting me to give a talk on decompressive hinge craniotomy. As you said, I'm from Copenhagen. We started doing this surgery a few years ago, and I'd like to give a report on our experience. I just have to say I have a research grant from the Danish Victims Fund. But first and foremost, thank you to Mr. Kalias to really exemplify the classical dilemma for a trauma neurosurgeon, whether or not to replace the bone plate. That has been the usual dilemma. And I would like to present decompressive hinge craniotomy as a alternative which can perhaps achieve both. So first and foremost, what is a decompressive hinge craniotomy? Well, basically, it's an alternative to a hemicraniectomy. So it's a large bone opening, a large craniotomy, similar to a hemicraniectomy. It's a dural opening, but instead of taking the bone plate out, you fasten it or hinge it or anchor it in a way so that the bone plate is dynamic. And this ensures that if there is brain swelling and bulging in the time after surgery, that the bone plate will slowly be displaced laterally. So that will relieve ICP issues to some degree, and there's room for the brain to swell and avoid herniation or elevated intracranial pressure. So the second advantage is that when brain swelling subsides, well, the patient will have atmospheric pressure pushing the bone plate from the outside back into its anatomical position, so the patient won't need any follow-up cranioplasty. There's also some reports on reduced complications of those complications you usually associate with a craniectomy, as seen here on the scan. So I'd just like to illustrate this with a case from my department. This was a 35-year-old man. He had an electric scooter accident and was GCS3 at the scene, was brought to our trauma center and had this scan upon arrival, which showed a thin subdural hematoma, traumatic subarachnoid hemorrhage, and small contusions at the base of the right brain. He went on to have an ICP monitor placed, and it showed an ICP of about 22. So he was taken straight to the OR and he had his subdural hematoma evacuated. And due to some light to moderate swelling, the surgeon chose to do a hinge craniotomy, as shown here on the scan. So this was the scan the day after surgery with the bone plate displaced due to the swelling. So the patient had some ICP liability for the next 2 weeks, which was medically manageable, and he spent a total of 21 days in our NICU, but then went off for rehabilitation. And we didn't see him again until a year later, where he came in for a follow-up. And in the meanwhile, he had the scan performed, which showed that his bone plate had migrated back into its anatomical position. And a year later, he was fully recovered from his trauma. So just to exemplify here that hinge craniotomy is a umbrella term, you might say, for different variations or techniques which have been published on different names. So on the left here, you see something called the open door technique, in which you cut the bone plate into 2 pieces and suture into the skull, and then the bone opens up quite like a saloon door. In the middle here, you see telescoping plates. I don't think they've been to clinical use yet. And on the right side here, you see some of the first reported hinge craniotomies using simple plate hinges. So in Copenhagen, we've developed our own technique, and this is a very simple technique, which is quite similar to how we perform hemicraniectomy. So it's a large incision. We place a burr hole at the coronal suture and take great care to do a straight craniotomy line from there, parallel to the sagittal suture. So we can place a long titanium strip hinge over that area. This allows for the bone to be very stable on the anterior-posterior axis, but it can be displaced laterally, especially over the medial fossa. We also make sure that the skin or the subgaleal space is lifted up and loose, so that the soft tissues allow for the bone displacement. We also ask the surgeon to decide during surgery whether or not it's safe to perform a hinge craniotomy or it should be a regular hemicraniectomy. So obviously, the goal of surgery is to have ICP control, perhaps not a low ICP, but one which is medically manageable, and also to avoid compression of the brainstem. So that's why the hinge is placed parasagittally, so you have the maximal bone displacement at the base of the brain, where most contusions, for instance, are located, compressing the brainstem. Another feature of the technique is to avoid compression of bridging veins, and this is usually seen in craniectomy from the bone defect along the parasagittal edge, and that's avoided by having the bone plate at the parasagittal bone edge here. Just one more feature from the technique, it's that it's very important to be careful around the soft tissues, especially when dissecting the muscle of the bone, to make sure that there's no trauma which causes edema or swelling of muscle or skin afterwards, as this will restrict the effect of the hinge mechanism. And also, if there's a patient with a trauma in this region, you should probably avoid doing a hinge craniotomy if the soft tissues are swelling or severely affected. So before we even started doing this, we wanted to investigate what was the effect of a hinge craniotomy compared to a craniectomy in terms of volume and pressure. So we did this cadaver study. It was very simple. We performed a large craniotomy and either fixed the bone plate, performed a hemicraniectomy or a hinge craniotomy, And then we slowly expanded the intracranial volume. You can see in the middle photo here is the expander, and we gradually increased the volume while measuring ICP. And it gave us these pressure volume curves. So if you see on the curve on the left, you see the curve for the fixed bone plate. It's quite rapidly rising, kind of resembling the Monroe-Kelly doctrine. If you look all the way to the right curve here, the gray one, it's the craniectomy, and this one shows that obviously there's a major right shift in pressure volume curve from a craniectomy. And not surprisingly, a hinge craniotomy falls somewhere in the middle in terms of its pressure volume curve. Of course, this is in a cadaver. So when we look at a threshold level of about 20, a craniectomy allows for 160 milliliters more of added intracranial volume compared to a hinge craniotomy, which is only 60 milliliters. And this difference is partly explained by the bone plate itself. The bone plate is about 80 milliliters. But you need to be aware of that the decompression is way less in terms of volume. And this is also something to be aware of when choosing the treatment for patients, that a craniectomy is more effective in creating volume for patients. So you should still reserve decompressive craniectomy for worst cases, but mild to moderate brain swelling is perhaps quite as effectively treated with a hinge craniotomy. So this is an excellent review from about 5 years ago from the Cambridge group, which reviewed all the published studies at that time of hinge craniotomies or similar techniques. They had about almost 300 patients showing a survival rate of about 75%, which is a lot like what we see in decompressive craniectomy. Only about 3% of all these patients required a salvage craniectomy, meaning that they had failure of their hinge in controlling their ICP. And of the 15 studies in this review, only about 6 of them were comparative studies, which reported equivalent control of ICP between hinge and regular craniectomy. And also they reported that they had fewer or reduced complications from a hinge craniotomy compared to a decompressive craniectomy. A more recent publication is this one from India, which also features Peter Hutchinson from Cambridge. And they have their own technique. They call it the expansile hinge craniotomy. And they sutured the bone plates together, cut it into 3 pieces, and then attach it to the skull. And they've done a very interesting non-inferiority study, which they prospectively randomized patients who had a craniotomy after trauma, which had a brain bulge above the inner table of the skull, but below the outer table. And what is really interesting is when we look at their follow-up 1 year later, because even though this is a non-inferiority study, so it's not powered to show any difference, but there's an interesting trend here when you see that about 1/3 of the patients from the craniectomy group had a good recovery, whereas more than half of the patients in the expansile hinge craniotomy group had good outcomes. And obviously the p-value here is not significant, so we can't extrapolate too much from this data, but it's an interesting trend nonetheless. So why should you even choose a hinge craniotomy over decompressive craniectomy? As Mr. Klaas just showed, it does have some very well proven effects. Well, perhaps there is some benefits, and one of them is simply put the tamponade effect. So what happens when you perform a craniectomy, if you think about it? You have a patient with a brain under severe pressure, compensatory mechanisms are depleted, autoregulatory function is perhaps dysfunctioning. And then you take off the bone plate and open the dura. And what we see is often contusion, blossoming, severe edema, perhaps rapid edema, but also extracalvarial herniation, which can cause axonal stretching, a proponent which could explain why craniectomy could lower functional outcome in some patients. Another benefit from a hinge craniotomy is that you can perform it preemptively in patients, and compared to a craniectomy where a preemptive surgery has a lot of consequences for the patients. They will have to have months without their bone plate. They have a lot of risk. They need to go through a cranioplasty. Well, a hinge craniotomy offers the potential for decompression without the risk of further procedures. So some of the inherent risks from decompressive craniectomy are reduced. So patients do have some bony protection of their brain, also in the time in rehabilitation. You avoid, for instance, syndrome of the trephined. The patients don't have to go through cranioplasty, and also that they can continue their rehabilitation without suddenly having to go back for surgery with cranioplasty. And obviously, there's one other factor, that is that it's perhaps also very cost effective in reducing the amount of surgery having to be performed. Here I have a case from my department of a patient who had a preemptive hinge craniotomy. This was a 69-year-old man. He had a bicycle accident and was brought into our trauma center. He had, as you see on the scan here, contusions and a burst temporal lobe on the left side, also a small subdural hematoma, and he became more drowsy and GCS7, and was taken to the OR where he had the subdural hematoma and contusions evacuated. Because there was some expectation of brain swelling afterwards, he had a hinge craniotomy performed, but when we looked at the control scan the next day, everything looked very good, and ICP was normal, so the patient was actually extubated shortly thereafter and was sent off for rehabilitation a few days later. We saw him a year later when he came for follow-up, and as you see here from the scan, the bone plate was in its anatomical position, and the patient was cosmetically looking very normal. So he didn't have any issues from having a preemptive hinge craniotomy performed. So when you start doing hinge craniotomy, we do see some pitfalls, and it's important to be aware of that some of the principles of decompressive craniectomy are still true, that you need a proper decompression. So size is still matters. You can't have a small hinge craniotomy as you see on the scan here. You need a proper sized craniotomy and decompression of the medial fossa. It's also important to be aware of that you don't have the same efficacy on patients as from the craniectomy. So a patient might not come back for surgery with single-digit ICP, and if you do a control scan, the midline shift is not completely gone, and you still have to perhaps treat the patient intensively with anesthesia. Because it's important to be aware of that for the hinge to function, there needs to be elevated intracranial pressure. Otherwise, the bone will not expand. It won't push on the skin. So it's important to be aware of that to have the effect, there needs to be pressure and time for the effect to take in. So it's just important to be aware of that the pressure volume curve is changed. So you have a right shifted curve. So it's If the patient has ICP close to threshold levels, that's acceptable for some period because the skin will expand and give room for the brain swelling and slowly relieve the elevated ICP. So in Copenhagen, we've had 23 cases so far. Only a few of them have been TBI patients. We have a big cohort of stroke patients. We've had one patient who needed a salvage decompressive craniectomy. We had 2 patients with minor wound infections. We followed up patients, and at that time, 6 patients were dead. But among the other patients, we haven't had one who needed a follow-up cranioplasty or any other surgery, such as a shunt or anything like that. So we're quite happy with that. But obviously, hinge craniotomy is something that needs more research, and I'm very happy to hear that Mr. Calais has some interest in this subject, because my hope is obviously that someday we'll see a large multi-center RCT on this subject, both for TBI patients, but also for malignant median infarction, for instance. So at this moment, there's no RCTs registered on clinical trials. But if you have any interest in setting up one, I'd be happy to hear from you and participate. So that's all from me. Thank you.
Thank you, Christian. Very impressive also. I like it a lot. We have time for 1 or 2 questions. Meanwhile, we had some questions from the audience. So one of the questions came from Dr. Ghosh. So is there a standard size and dimension of the hinge craniotomy you follow in your department? Christian?
So basically, we recommend to do it along the same principles as a hemicraniectomy. So 12 by 15 should optimally be the standard issue. But obviously, this is something for the surgeon to decide which fits the patient the best. And this should also be fitted for the specific case.
Yeah, exactly. Yeah, clear. So one final question from the audience, and then we move on to the final question. We're slightly over time already. So how do you, this is from Dr. Riso, how do you perform duroplasty and dural closure for hinge craniotomies? Are there any issues with CSF leakage and with wound dehiscence in the early brain deswelling post-operatively?
So we haven't had any issues with CSF leakage. We either put on a pericranial flap or artificial dura substitute, and we use a simple onlay. We don't do duroplasty, so the procedure is very fast and easy to perform, and we haven't had any issues so far with CSF leakage.
Okay, thank you. So yeah, I'd like to introduce our final presentation. Again, thank you, Christian. If you can allow Sandro to share his screen. So Sandro Kriek, Professor of Neurosurgery and Department Chair of Heidelberg University Hospital in Germany. He has an impressively wide array of research interests, I must say, among which innovation in severe TBI management is one of those. And today he'll give a presentation of a laparotomy, that is abdominal decompression, of course, for treating refractory raised ICP in TBI patients, and how that compares to the established intervention, decompressive craniectomy. So thank you, Professor Kriek, for joining our webinar, and I'm looking forward to your talk.
Thank you very much for the introduction. Yes, I'm actually coming scientifically from a long time. I came from TBI research, so it's kind of a circle now. Good. So a great introduction. There is not a lot to add to the introduction, just the disclosures. We heard, I mean, this is data from the German registry on TBI and the complications. And if you look at this, we heard in the other talks, in 130 enrolled patients, we had 206 complications. So there is still, and we see this in this great webinar, that there is some room for improvement. Looking at Monroe Kelly, all of you know, we have in the brain, of course, several spaces, but beyond CSF and brain, we have the arterial, but also the venous blood volume. I think this is crucial and some people forget it. So while you drain CSF while you reduce the arterial volume a bit by sedation, the venous blood volume is very rarely in any way kind of dealt with. So the basic principle is reducing venous volume as well, because at the end of the Monroe-Kelly doctrine, as we saw, you need only a little gain of space to have an effect on ICP, which might be enough. So this is the blood volume, but there is also another theory now on the venous or on the outflow, so the venous outflow itself. So the more outflow you have, the more ICP reduction you have, because it also sucks CSF and fluid from the brain. So venous outflow, not only venous pressure, seems to be important at least. And there are some, so what to do? You can, of course, reduce venous drainage by several things. This is the most described, rarely described, but still the most described methodology currently, which is still rare, is doing a decompressive laparotomy. When I first kind of stumbled over it, I was also a bit kind of, wow, what are you doing there? But when you look at the largest series, which is already done in Baltimore, like now 20 years ago, and you look at the data, it's not that bad actually. So this is, in this series, we have 17 patients with decompressive laparotomy, and all of them failed medical therapy, and most of them had already decompressive craniotomy. And if you look at those who had then sustained ICP, and were operated by decompressive laparotomy, so it's like the whole from xiphoid down to the pelvis. You see here pre and post decompression ICP in these patients, and you see how it really drops. So from 30 on 70.5 millimeter mercury. But if you look at the other data beside this, which is this is not middle arterial pressure, it's middle abdominal pressure, and the central venous pressure, you don't really have that much of reduction on the pressure. So it really seems to be a flow effect and not that much a pressure thing. And still patients benefited well. So we have, as we heard, we have a lot of complications by our standard treatment. We need to have something again additionally. So this is why we thought it would be time to have a prospective study on dealing with this question, if we can have any kind of other treatment. And if you look at the laparotomy complications and you ask abdominal surgeons, and I have actually a lot of abdominal surgeon friends, and they say laparotomy complications is like 2 to 3% overall. So compared to decompressive craniectomy, this is really nothing. So we designed this study. Actually, we looked very much at the rescue studies as well, because it's kind of the international standard, as we saw and heard. We chose a randomization and intervention, which is direct intervention, laparotomy versus craniectomy. But what we want to do to have a comparable pilot study, having 20 patients first, enrolled 10 versus 10, and then make a safety analysis. And if the interim analysis is fine and safe, we go on with the trial and enroll another 80. Primary outcome measure is, as we also heard, the extended GOSI, 12 months post-injury. As you also heard, first and second tire treatment, so very comparable. This was important for us to make it also comparable to other studies and the standard studies we have nowadays. So it's the regular protocol. We also then, this is a thing in Germany, it's more like 20 millimeter mercury is the border in many countries. So we decided like for 20 millimeter, not 25. And if it still is high and you think about craniectomy, this is the study entry where the patient can get randomized. we chose more younger patients as well, with TBI, and of course an invasive ICP monitor, and first and second tier therapies already done. ICP, again, as we heard, 1 hour at least increased. Exclusion, this is important. It's bilateral fixed pupil, not unilateral. And any kind of disability, of course, which reduces the outcome. Any injury, intracranial or interabdominal, which mandates laparotomy or craniotomy itself. And there is also a model on acute consent. As you know, you have a legal representative or a per proxy. And then the important thing is to know, we try to make it as safe as possible for the enrolled patients, of course. So what we do is now is that the randomization is done in the neurosurgical OR. Patient is operated there. So actually every center can decide, but this is currently as the enrolled sites decided for. And if so, craniotomy or laparotomy is done. You don't need really a lot of things and tools. You need mostly scissors and a scalpel for a laparotomy, which is a 3-minute thing actually. And then the patient remains. So we don't drive the patient all through the hospital and make a CT scan and put him on the ICU where everyone attaches several lines and everything. So we keep the patient in the OR, no touch, and see if the ICP falls down. If it doesn't fall, patient is then decided for crossing over for an hour. So we have at least a reduction of ICP within the hour should be accomplished by the therapy. So it needs to be below 20. Otherwise, patient needs to have a crossover. So these are our like standard operating procedures. I will very quickly go through it. It's a standard. What we put in is a vacuum therapy, so negative therapy, pressure therapy. And then it depends, usually after, it's about 72 hours post decompression. The abdominal surgeons start closing it, and they can close it step by step or in all together already. Depends on the interdisciplinary consents. And the same with craniotomy. This is completely standard cranioplasty when ICP is down, depending just on the center's standards. Current state is we have 4 initiated centers and we have more with contracts done, and most of them the ethics committee confirmed already. We also have 1 enrolled patient now who got enrolled and who had, for the course, he actually had a drop in ICP about 13 millimeter Hg, and then had to undergo craniectomy. He was randomized for laparotomy and then was on the ICU, and on day 4 had a craniectomy. So it actually worked for like 3-4 days. I can still not sure why he then worsened again. There must be something underlying, but still we had a drop in ICP for around roughly 13 millimeter Hg, which is actually the average the old paper found. And I think this might be also the most suited approach if you need 10 to 30 millimeter Hg of reduction. If you have a patient with 35, 40 millimeter Hg, I'm still not sure if a hemicranectomy helps then, because, I mean, you most of you know, but this is the current state. So these are the investigators. It's actually by the German Ministry of Defense, founded, publicly funded, and it's still run by my old institution, the study center in Munich, because we didn't want to move study centers, keep it easy. So that's it, quick run through the study, and I'm open for questions.
Thank you, Sandro. Very impressive talk. And I am looking at the screen. There are no questions from the audience. Christian or Angelus, feel free to ask Sandro something. Sandro, I I have two questions actually. Let's see how far we get. But first is more methodologically. So you explained that you keep the TBI patients in the OR after the intervention for an hour. And if the ICP doesn't increase, you transfer them to the ICU. So for the laparotomy patients, I can imagine there's a crossover. You actually refer to one case. But what happens if a patient has been randomized to decompressive craniectomy? Do you also keep them for an hour on the OR and see and what do you allow a crossover to the laparotomy group also? Okay, so
Yes.
both ways.
We want to make it very comparable, of course, and it was ethically quite a problem because the data is not good. So the major goal is to have now good data, right?
Yeah.
So does it work well or does it not work as good as we think? So we had over the years, it was like 3 patients over the years which were not randomized but underwent laparotomy. One had actually a exploratory laparotomy or 2. And the abdominal surgeon said, I will not put in carbon dioxide in the ICP raised patient. So they did a laparotomy for inspection and then kept it open. And ICP dropped like nothing. And then we had a other one who had a thoracic trauma as well. And he had to undergo kind of lung replacement, or not lung replacement, but oxygenation. So how you call it? The transvenous oxygenation, which also decreases the venous or increases the venous outflow, and the ICP dropped as well extremely fast. So, and if you talked about to trauma surgeons, actually, some of you will also report that they had a case in their career. So it happens.
Yeah, and a nice anecdotal examples. You mean? Yeah. No, thank you for your answer. So other question I had is more or less in line with the question I see popping up now from Dr. Saleh. So who performs the laparotomy? He asks, or she asks. General surgeons or the neurosurgeons, and if neurosurgeons, are they specifically do they get a specific training for?
No, we do it. So the whole study was outlined and planned with the general surgeons, and also the initiation of the study. You have a general surgeon there. I also went at my one institution. I will go to the other as well in Heidelberg as soon as it starts, to the whole general assembly of the general surgeons and tell them about the trial. And then just a general surgeon on call does it. For them, it's very simple procedure. We have like standard sheets on the wall in the OR saying what they need. So what the nurses need, it's just really a standard tray. You can do it with every new surgical discectomy tray or whatever.
Yeah. So we can also do it.
Yes, but again, we wanted to make it as safe as possible for the patient. Yeah. And
of course.
So we said that this needs to be done by the general surgeon because they are like, it's really like 3 minutes.
Yeah, no, that's clear. Thank you. So I have another question here from attendee, but a follow-up question to this topic I had is, how is in general is the response of the general surgeons? I think it's an intervention that all general surgeons do, but or is it specifically delegated to the abdominal surgeons or the trauma surgeons? So that's
actually in Germany, the abdominal surgeons, they actually love it because for them it's something they don't know. And usually they are very pushy in what they do, so they have no issue. The bigger problems come from anesthesiologists, for instance, because they say, well, I then have to have 1 hour and anesthesiologist mostly during the night on call in an OR and can't do another surgery. But yeah. I mean, the cases are rare still because of also the inclusion criteria, so it doesn't happen that often. This is a major argument. But yeah, surgeons don't have a problem. With the ethics committee, of course, we had some discussion. Actually, all members told us they think that it works. But they also had a problem with the, because you open another field of the body to treat another pathology. And this is, of course, something to think about. This is why we set it up as we did, also with the hour in the OR, and really make sure if patient needs a craniotomy that he gets it as soon and fast as possible.
So I have 3 questions here left that are all on the technique of laparotomy. So in general, could you tell a little bit about the technique and specifically to attendees remark about the closure? So how is the abdominal wound closed? And the other question is how the extent of the laparotomy. Cape to Cairo, I assume that is from xiphoid to symphysis.
Yes.
So
it's
can you elaborate on that?
symphysis. Yes, but actually, I have also one general surgeon from Munich who was thinking about doing it endoscopically because he said he can keep the skin and just open the fascia. We didn't do it yet because this also adds a lot to. But we will do it maybe after the 20. I don't know. But it's usually xiphoid to symphysis, and then you put in a negative pressure drape, which usually the general surgeon everyone has in the hospital. You just put it on. So wound closure is quick, and then after 3 days they start adapting it.
It's pretty standard for them, right?
Yes. Very. And we keep it to the center. Some of them want to bring in a net. But actually, we didn't have the discussion yet because we leave it to the expertise of the general surgeons in each center.
Yeah, indeed. So the technique is done. We're about to end our session, but let me see if there are any new questions. Yeah, when do you close the laparotomy? You addressed that, of course, but can you please answer that question again?
I mean, the problem is, as you know, if you put in a negative pressure drape on the spine, right? If you keep the wound borders apart from each other, you don't bring it back after several days. So we try to, after 3 days, we talk with them to try it. And sometimes they start from each rim and try to close it already partially and then again. But
Yeah, 72 hours is the answer, right?
Yes.
So Angelos has a question. Please go ahead, Angelos.
Thanks, Thomas. Sandro, great presentation. Good luck with the study. Just want to clarify at the moment, how many patients have you randomized? Did you say in the study?
We have 1 randomized in Munich now.
Okay. Oh, good. All right. And how long has it been going on for? In terms of how long have you been open as a randomized trial? Not the setup, but when were you able to accept randomizations from?
Munich was randomized end of last year.
Okay.
And the others are just now coming.
Okay. So it is going to be a little bit slow, I guess. So what? Yeah. So what do you do with the other patients that have issues with ICP and you don't randomize them in the study?
Which others?
I mean, so you cannot have had just one patient that had raised ICP in 5 months, right? So you must have some other.
It was really winter. I really asked them, and I asked them like every month.
But probably you would have treated them then if you would have more patients with decompressive craniectomy then, right? If it would out of the would have been.
The problem is if they have acute subdural hematoma, you can randomize them.
Yeah.
Or if they have abdominal issues, injuries, or whatever, you can randomize.
And if they have so you only randomize those with contusions, right? Or
yes.
Okay.
So it depends. If you have a pathology which necessitates craniotomy, you cannot randomize. That's the biggest limitation, I think.
Okay. All right. Understood. All right. Well, good luck. I hope it goes well. And can I just make a comment to Christian? Christian, just let you know that the EANS Center in Bangalore in India, who are collaborators as well.
Yeah.
So they're just about to initiate a randomized trial of decompressive craniotomy versus craniectomy. So we are helping them with that. So they're just about to roll it out. I think the sample size, if I remember correctly, is about 450 patients in TBI. So we'll let you know about that.
Great.
Thank you.
That's magnificent, and that's primarily led by the Indian Center, Angelos.
Yeah, so that's part of our global neurotrauma group. So
Yeah.
you know we are supporting them, but yes, it's led by them. Yeah.
Yeah. Okay, so I'd like to finish up. There are no more questions from the attendees. We're 20 minutes over time. Sorry for that, but I think we had a very impressive almost 1.5 hours, and it's clear that surgical techniques in severe TBI has a promising horizon. I want to thank all the speakers, and I hope to see all the attendees for our next neurotrauma webinar. Good evening, good morning, and good afternoon to everybody. Thank you again.
Right. Bye.